Hello, welcome to PACOP Clinical Bites. My name's Laura, I'm one of the improvement facilitators for PACOP, and today we're going to spend 5 minutes talking about the Rockwood Clinical Frailty Scale. The Rockwood Clinical Frailty Scale is one of 6 standardised assessment tools in the PACOP suite, and it's utilised in both the profile and the outcomes collections. So let's talk about frailty. What is it? Why do we assess it? And why did we use the Rockwood Clinical Frailty Scale? Well, frailty is a state of increased vulnerability to stresses and due to age-related or often disease-related deficits that accumulate across multiple domains. Frailty is a state of increased risk and vulnerability, and like the risk of dying, frailty tends to increase with age. So when we understand frailty, we're better able to meet the needs of our residents who live with it and monitor them for changes. We assess frailty because new research supports this tool as an excellent prognostic indicator for monitoring for resident decline, and it's also the tool of choice in the ANAC funding model as it's validated for use in over 65s, which makes it perfect for use in the aged care sector. So this is what the Rockwood Clinical Frailty Scale looks like. There's 9 levels, and it's based on the Canadian Study of Health and Ageing Frailty Index. It's a clinician-rated tool, and we use it to assess the resident at the point of the care assessment. So we can see here, level 1, 2, 3, and 4. We're starting off with someone who's very fit, no disease-related symptoms, and they're the fittest for their age. As they increase down to level 4, their physical activity is starting to decline, and they're starting to need more healthcare. As we get to level 5, 6 and 7, we can see that there's increasing physical and cognitive support required for them. And level 8 is someone who's very severely frail. Typically they could not recover from even a minor illness. We can see when we get to level 9, this person's sitting in a chair. This is someone who's approaching the end of life. And this category applies to people with a life expectancy of less than 6 months who are not otherwise evidently frail. So this is somebody who we probably won't come across too regularly in aged care. Most of our residents where we've identified the need for palliative care and approaching terminal will become level 8. They've got significant physical and cognitive impairments and they need some additional support. So when we're scoring someone using the Rockwood Clinical Frailty Scale, we really need to think about some of the domains that frailty can affect. So we're looking at their energy and physical fitness. We're looking at active disease symptoms, level of dependence, and their cognitive status. We need to ask ourselves questions about the resident so that we get a holistic picture of their current health. Maybe they've had a GP review or some medication changes. Maybe they've had an increased need and use some equipment now. Maybe you've noticed that they're starting to need a bit more cognitive support and you need to cue them through their ADLs. These are all things that are really important to consider to make sure that we're accurately scoring our resident and not missing those chances to pick up declining health. The great thing about the Rockwood Clinical Frailty Scale is that it takes into account both physical and cognitive frailty. And so when we're looking after residents with dementia or Alzheimer's or a cognitive impairment, we really need to use our critical thinking and not just look at the prompts and the descriptors, but make sure we're really aligning with where the resident's currently at. So this is where someone with perhaps a mild impairment would sit. They're starting to slow down a bit more. They need help with the higher order ADLs. And usually a good test would be to give them a couple of instructions and see if they can follow. Someone who's then got a moderate impairment, we can see they're starting to need help inside as well as outside. And they're starting to need some more cognitive support and cueing with these day-to-day ADLs. And here's someone with a severe impairment. Someone who's completely dependent for personal care and ADLs, they need that constant support and cognitive prompting, and they probably will need some physical assistance as well. Even so though, they seem stable and they're not at high risk of dying within 6 months. So now that we've gone through the tool together and we've had a talk about some of the descriptors and some of the pictographs, let's give it a go. So I want you to think about one of your residents. Maybe it's someone you've looked after for a long time, or maybe it's someone you just met last week. What score would you give them? Now think about those questions, their fitness, their disease, their level of dependence and their cognition. How much prompting and cueing do they need? Do you need to change their score? No? Well, congratulations. You've decided on a final score and you can use the Rockwood Clinical Frailty Scale, and you understand why measuring frailty and assessing it is so important for our residents. And so that's the Rockwood Clinical Frailty Scale. Thanks for watching the PACOP Clinical Bites. I encourage you to watch the rest of the videos in the series on our standardised assessment tools. And for more detailed information, you can contact your local PACOP contact, or you can send us an email at pacop@uow.edu.au. Thanks, and I hope we see you again soon.